Um, Thank you for having me. That was a very nice introduction. Thank you. Um, I've been spending a lot of time over the last year thinking about how do we deploy AI in medicine in a world in which it's very likely that at least on a subset of tasks, we're going to see superhuman performance. What's the role of the AI? What's the role of the human? Is very much at this point a unknown territory. I started really looking at this in 2023. This is work done with some colleagues who are economists at MIT, in which we're trying to understand, do AI tools actually improve physician performance? Does the combination of the doctor and AI outperform the doctor or the AI alone? And the way we set up this experiment was with 227 radiologists that were interpreting for the presence or absence of 15 different conditions on chest x-rays where they received AI assistance and clinical context. So what you see on the left is the x-rays along with the probability outputted by an AI model. And on the right, you can see the clinical indication and the vitals in this case for this patient. So allowing for a truly multimodal interpretation by the human. And so I want to tell you what was the surprise in this integration is the AI actually worked pretty well. In fact, it outperformed 78% of the radiologists by a couple of different metrics. But the key was that when used as an assistive tool, actually did not improve the performance of radiologists on average. That's interesting. Something that's better than 78% does not improve the performance of the users on average. The integration works when the AI shows high confidence. You can see a positive treatment effect as a result of having AI. But if the AI shows prediction uncertainty, that's when you get a negative treatment effect. That means it actually hurts to have AI assistance compared to not having any assistance at all. If we could predict when we were going to fail, when we were going to succeed, who we were going to succeed and fail with, that would be great. If I could a priori say, here's a survey. If you pass the survey as a physician, I'm going to give you the AI. If you don't, I won't. That could be very effective. Thank you. This was a study done with 140 radiologists across multiple experience level specialties. And we tested, do years of experience, your specialty, and the experience with AI tools, are any of them predictive of whether or not someone's likely to benefit with AI assistance? It turns out none of these three factors are actually predictive of whether or not someone improves with AI assistance if they're a physician. And the implication for this has to be if there is heterogeneity, which we know there is, and we can't predict who's going to benefit, who's not, this idea of one size fits all deployment is really not going to work. And we need to think about a way of measuring individual response and personalized implementation to actually make that integration a success. There's a broader pattern of failed collaboration across several imaging studies and outside of imaging studies with text-only diagnostic challenge studies as well, where the combination of the AI and the human actually performs worse, significantly brings down the performance of the AI-only predictions. And that's fascinating from a behavioral standpoint, certainly fascinating from an integration standpoint of how we move forward. I don't want to make this a downer in terms of here's all these ways we failed. There are ways we've succeeded, and I want to highlight some of the ways in which we've seen big successes. In terms of trials, one of the large trials running out of Sweden had the following setup in which a mammogram is first read by an AI, and depending on the prediction, if it's highly confident, is only read by one other human. If it is not highly confident that it's normal, is actually read by two humans, which is the standard of care in Europe. What was found is that in a setting in which you had this AI determine whether or not there should be one reads or two reads, there was an increase in the amount of cancers detected and at the same time a reduction in the workload as a result of having this AI-assisted triage to double reading. Here's another study, this one out of Germany. This one is a natural experiment. So what it does is it lets the doctors decide when they want to use AI, when they don't want to use AI. And what was found is very, very counterintuitive, is that the doctors decided to use AI assistance for routine cases, but when they were presented with a complex case, did not actually decide to turn on the AI at all. That's very interesting. So I asked the question, why are we creating a forced collaboration where there might need to be some other way of extracting the strengths of the human and the strengths of the AI? And we've now had plenty of evidence for that. We should at least ask this question, if not transform the way that human AI collaboration actually happens. This is a guest essay I wrote with Eric Topol in the New York Times, which was unfortunately titled "A Robot Doctor Will See You Now." So one of the propositions here is, rather than thinking of having this AI as look over your shoulder on every single thing that a physician is doing, why don't we think about a case of role separation? Let's truly have the AI do something different. Let's have the human do something different. That's the way we're going to leverage their complementarity, their strengths, and be able to produce the synergy we're lacking right now. So how do we do this? I'm going to share with you two examples today. One of them is going to be one in which we have the AI do something before the clinician, and the second in which we have the clinician do something before the AI. Now, the third model is to decide for a case whether it should be done by a clinician or done by an AI, or as we saw earlier, done by one clinician or two, and that's something I'm not going to cover in any further detail right now. But let's focus on the first two, and I want to kick us off with our first example here. This is called CraftMD. This was a Nature Medicine publication from my group last year, led by one of my PhD students, Shreya. And Shreya had the following question, which was, we evaluate these models that look at images and look at clinical text on these very static settings, which is, here's the patient scenario, what is the diagnosis? They do pretty well. But that's not how most interaction works in the world, as people go and don't explain their symptoms in beautiful English or whatever language. It has to be a back and forth between the clinician and the patient. Okay, so how do you simulate that? How do you make that a real benchmark? That is what CraftMD does. So I'm going to show you through an example. So the basic premise is, if you had images, you had the case vignette, you'd present the question answers to a clinical large language model. It would get it right. In this case, say leukemia. This is not, something benign that you don't have to worry about. Very clear that it's got the answer right. What we're now going to do is we're going to transform this question into something that is going to evaluate the history gathering capabilities. And so for that, we have this simulated doctor-patient interaction now, where this patient AI agent comes in, says, here's what's going on with my son, and go back and forth with the clinical LLM, where the clinical LLM has to hopefully come back and say, this is serious, this is leukemia, and should be looked at. But instead, what you'll see in a second, the LLM says is, after all this questioning, this seems to be non-specific limb pain. Why don't you take some ibuprofen? There goes your leukemia. And so what this speaks to is a larger error category, where in going from these static question and answers to actually this conversational setting, we see a big drop in the performance of these models. And so they struggle with the history gathering abilities, the ability to synthesize all of that information together and come up with the diagnosis. All right, so we've talked about a case in which the AI goes first, and then doctor might even review everything that the AI has history gathered. I've shown you an example where it doesn't work right now, which is in the case of history gathering with LLMs, but it's possible in the future this works. So now I'm going to show you a second example where we're flipping the order of the AI and the clinician, where we're going to say the clinician comes in first on a scan, interprets the scan, and then let's have an AI be responsible for interacting with the patient and explaining the scan and the report to the patient. So this is work led by one of my postdocs, Luyang Luo, and Luyang had the idea of building RexPlane, where in this particular case, what we're going to do is we're going to show a video report of the patient scan, which includes the text that's been said by the doctor, but simplified in a way that can be understood by a patient, but more importantly, corresponded to with regions of the image. So this is being able to link regions of the image with key findings. And on the right, once we have the segmentations that are relevant, are able to generate the 3D rendering. Now we're able to compare what that patient scan looks like in the abnormality with an age-matched normal. So now we can see that here's what that should look like without the abnormality. Very interesting idea. And what we did was we showed interpreting physicians.
Radiologists acknowledged the results.
Sorry, what's that? Okay, I think that might not have been meant for me. But we showed the treating physicians these videos and asked them, would you feel comfortable if the patient looked at these, with your supervision? We're like, yeah. Would you feel comfortable if patients looked at these without your supervision? It was like, no, 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 don't ever do that. And the fear is about what happens if the patients get unnecessarily worried about their own scans, looking at these videos. It's like, should I be worried about this? And that's something we're actively working to be able to solve in some capacity through better explanations. Okay, so I want to talk a little bit about the way that the modeling and the approaches have evolved in our field over the past few years. In 2023, we wrote this Nature paper called Foundation Models for Generalist Medical AI. And the big push at the time was to say we should stop building specialized models that are only trained for a subset of tasks. We should think about unifying as much as possible the training process, the architecture, the task types into one modeling framework. And we want to be able to do this in a way that not only looks at text, but is able to go truly multimodal, and most particularly be able to look at medical images, volumes, videos together as part of this unified analysis. Just early this year, we fleshed that out a little more in a Nature perspective called GenMI, in which we say the future of multimodal generative AI will be to look at this various forms of data and be able to communicate in crystal clear language what's going on and any interactions which have to be done as a result of looking at this multimodal data. I want to share with you one concrete example of multimodal generative AI in action, and this is work done by a former postdoc of mine, now starting as assistant professor at Tsinghua. This is Hongyi Zhou, and he built out MedVersa. And our idea with MedVersa was to say we're going to unify various types of vision language and vision tasks that are relevant for medical imaging interpretation. And core to MedVersa was the idea that we could batch up different tasks and be able to orchestrate whether something should be a language output or require some sort of a vision output in terms of a bounding box or segmentation. And those are modules which can be leveraged by MedVersa. What we did here was compiled a data set using public data that captures different task types, that captures different imaging modalities, and brings them together as part of one unified data set. Now, I won't go too much into how this was accomplished, but the main idea here was demonstrating that on these different benchmarks, on 9 out of 11 benchmarks that we chose, we set a new state-of-the-art performance, where previously the traditional paradigm was you would build a specialized model that did really, really well on that particular task setup with that particular data. Now we're saying this is not something where because you train on one task, you lose out on performance in terms of another task. I was particularly interested in not what this meant for static metric measurement, but what this meant in terms of the clinical validation side of things. And here in particular, how do things compare with people? Are we able to put people's reports and the AI reports side by side and have people say which one is better, which one is not? And what we found here was that 71% of AI-generated reports, here in the case of chest X-ray interpretation, matched or exceeded the human-generated reports in a blinded assessment. 58% equivalence of superiority in abnormal findings, and for routine cases, 95% reported equivalent or superior. I expect this to be very different a year from now, where we should expect that the abnormal bucket will look very different in terms of where AI reports are superior to human ones. Now, you can use this as an assistive mechanism by saying we're going to start with AI drafts that people are going to modify, and it's going to save them time. It's going to make them more accurate. And we did find this to be true, but the key was that it was high variability depending on the user that was using them in terms of how much benefit was accrued as a result of our AI drafts. We now have a leaderboard for tracking progress on this task. It's called the RexRank leaderboard, and RexRank right now tracks a couple of benchmarks, but you can visit it live on rexrank.ai. We have several different data sets. We have a couple of different tasks, which now include VQA, and version 1, which has a sorting by various metrics, and V2, which involves doing visual question answering. And so this is very much an open and unsolved benchmark today. Might not be open and unsolved next year at this time. So beyond my academic hat, one of the things I'm passionate about is bringing technologies for report generation to life commercially. And so I'm co-founder of A to Z, and I want to show you an example of the kind of systems that we're thinking about and building as part of that effort. So this is a CT scan where on the right, you'll see a multimodal generative AI has already gone through and outputted key findings on that particular scan. Each one of these is referenceable in terms of the image itself, what region it's looking at, and the task of the radiologist is here to be able to verify each one of these and be able to sign off on the report in this very preliminary way of saying we can now have rapid AI assistance for interpretation. One of the areas that I'm very excited about is the ability to simulate a whole electronic health record environment. And for us to do that, we're starting with a static data set called MC-Med. This is the most comprehensive emergency department data set of its kind, which has got about 100,000 ED visits. It's got continuous monitoring data. It's got complete clinical context in terms of labs, meds, orders, imaging reports, outcomes, and we're linking it with actual imaging as well. I just wanted to include on here that one of the reasons we haven't seen these technologies really take off in the US is that it's still unclear who pays for them, and that remains one of the primary barriers for these to be used everywhere. And there's some emerging pathways to reimbursement of these, but that remains to be very much a open and unknown area for us to think about peripherally. I want to end with some examples of research along the frontiers, one of which is a recent work from our group called Rex Gradient 160K. This is led by one of the postdocs in my lab, Xiaomen Zhang. And with Rex Gradient, our idea is to be able to expand on rapidly the progress in report generation on 2D modalities, and in particular chest X-rays. This is the largest data set by the number of patients, which has been publicly released with 109,000 patients. It took about 2 years of thinking to be able to put this together. It represents 79 medical sites and really allows us to get at some questions of generalization of these models in a very effective way in terms of the health systems that are involved, in terms of being de-identified and actually having structured reports paired with those images. One of the benchmarks we've built on top of this data set now is called RexVQA. And with RexVQA, we have one of the largest visual question answering benchmarks, but perhaps more important than largest is the quality. And I'll share with you over the next 2 slides what we've done on those fronts. One of the interesting excitements here has been that one of the latest models, which was released 2 weeks ago, actually performed better than any other model we had seen previously. And so we updated the paper. It's now live. which has the MedGemma result on there as well. But RexVQA still has room for improvement, and I expect this will be an interesting benchmark for frontier models and for you as you're developing to track progress on. One of the things I'm proud of in this work is that we focused a lot on clinical authenticity. That means really understanding what sort of questions make sense to include as part of this benchmark that reflect reality and have this iteration, validation structure, and review structure that really focuses on getting the quality right. One of the areas that's very unsolved right now is when these models are going to generate lines that are just untrue, what we call hallucinations. How do we actually identify them? Two of my students worked on a method called rat flag. Both of these were undergraduate students at the time of this work. That is a temperature-based sampling method to detect inconsistencies, and this flags hallucination without any access to weights required. And the basic idea is to be able to sample from the model, generate reports, and then look at consistencies or inconsistencies between the different versions of the reports that are generated at a line level, and be able to flag sentences that are consistent or don't have consistency between the reports. And we show how this can be used to flag and then eventually remove hallucinations. We're tackling this problem from different angles. This is work that is going to be presented at CVPR called Fact Checker. And with Fact Checker, one of my students, Alice, had the idea of editing the reports to be able to fix hallucinations. In this case, we're fixing anything that claims to locate endotracheal tubes on chest X-rays by doing what's called a query code update process, where we find areas where there might have been hallucinations, leverage a specialized model to correct it, and then update the model as a result. A lot of exciting work happening in multimodal generative AI as it relates to 3D medical images and videos, where there might be a unifying principle that allows us to get computationally at solving what have been traditionally out of reach for medical vision or vision language models. And in particular, the ability to create real-time predictions will enable a new generation of applications that currently are missing. Of course, when we think about the boundaries of what LLMs can do and their ability to access tools, I'm very excited about agents in advancing healthcare. And one of the ways that we've thought about agents is responsible for different data streams and communicating with each other in natural language as a way to get to address some of the challenges specific to medicine, like not having all of the data for all patients in one centralized place. So this is an imagination of a decentralized approach to tackling this, where we have agents that are responsible for different components of the pipeline, that have the ability to make orders, that have the ability to communicate with each other, not too different from the way we have human setups right now. I'll end by sharing that one of the things that's interesting and unique about our lab is the ability for us to work with people that are talented and interested in this space. We have a medical AI bootcamp, which is a 6 to 9 month research program, which is done during people's own time, where if you are a medical doctor, you can be participating from anywhere around the world. And if you are a student in AI, traditionally this has been open to Stanford, Harvard, and MIT, but we're opening it up to any student from around the world. And so just be on the watch out for that, and you can already submit your application. None of this would be possible without great colleagues, great lab members, and I'm very excited to be able to get the opportunity to work with them. I'll pause there. Thank you for having me.